Imagine you are a patient roughly 18 months out from an anterior cruciate ligament reconstruction.
The classic ACL repair.
Right, the classic repair. And for over a year, you have done everything right. You endured the initial swelling, the crutches, those agonizing physical therapy sessions, just trying to get your range of motion back.
Yeah, the rehab is brutal.
It is. And you've done the strength training. Your surgeon used a standard hamstring graft, a single bundle technique, and at your final checkup, they declare it a textbook operation. You are cleared.
I mean, from a purely mechanical and surgical standpoint, the box is checked. The hardware is in place.
Right. But here is where the nightmare starts. You go out for, a casual game of tennis. You feel confident. You run forward to return a volley. You plant your foot. You pivot to change direction. And suddenly, you feel that sickening, horrifying sensation. The knee physically gives way.
Oh, that is the worst feeling in the world for a patient.
And it shifts. It's highly specific, too. Like, it doesn't happen when you walk in a straight line or jog on a treadmill or climb stairs. It only happens when you turn, when you plant and twist.
So you immediately go back to the clinic, and the surgeon, naturally wanting to know if the graft has ruptured, sends you straight into the MRI tube to see what is going on inside the joint.
Exactly. You get the scan, the radiologist reads it, the surgeon reads it, and they look at you and say, well, the graft is completely intact, it's continuous, it has a beautiful, healthy, low signal on the imaging, meaning, it hasn't frayed or snapped, it looks absolutely pristine.
This creates, honestly, one of the most difficult, frustrating conversations in sports medicine.
I can imagine.
Because the objective imaging is telling the surgeon that the operation was a flawless success, and you, the patient, are sitting on the exam table saying it absolutely was not. The knee is unstable.
So we have a paradox. Who is right? Is it the perfectly pristine MRI or the patient who feels their knee buckling under them?
The patient is right. They are entirely right. And the reason why is going to take us the rest of this deep dive to fully unpack. Because it turns out that in ligament reconstruction, where a surgeon drills their holes, matters far, far more than what material they put into those holes.
Right.
A ligament isn't just a piece of string holding two bones together. It is a highly specific, multidimensional directional vector.
So today, we are going deep into the hidden microscopic architecture of the knee. Our mission is to take the source material we've gathered and decode the subtle, often overlooked clues of an ACL injury. We are going to explore the precise, almost maddening geometry required to rebuild a knee and uncover the hidden pitfalls in rehabilitation that can ruin a perfect surgery in seconds.
It's a lot to cover.
It is, but by the time we are done, you, the listener, are going to understand exactly why a visually perfect surgery can completely functionally fail.
To really grasp how a surgically repaired knee can fail a patient, we can't start in the operating room. We have to start with the native blueprint of the knee itself. When you look at an intact, healthy ACL, what is it actually made of?
See, I think most of us just picture one thick, solid rubber band sitting in the middle of the joint, anchoring the thigh bone to the shin bone. But diving into the anatomical breakdowns in the sources, it's, well, vastly more complicated. The ligament isn't a single band. It's split into these highly specific bundles. Two bundles.
Right.
And the names are incredibly dense. We have the anteromedial bundle and the posterolateral bundle.
The naming convention is dense, I know, but it's vital. The ACL is a two-part structure, anteromedial and posterolateral. And what makes this so notoriously difficult for medical students is that the ligament sitting right next to it, the posterior cruciate ligament, or PCL, is made of the anterolateral and posteromedial bundles.
Wait, slow down. They just flipped the words.
They did.
The ACL is anteromedial and posterolateral, and the PCL is anterolateral and posteromedial. That is just cruel. How is anyone supposed to visualize that? It just sounds like a directional word salad.
It is a bit of a word salad, which is exactly why we need to move past the Latin names and talk about what they actually do mechanically. The names simply describe where the bundles attach to the tibia, the shin bone. Antero means front, postero means back, medial means toward the midline, lateral means toward the outside. But practically, you keep them apart by looking at their tension patterns.
Right.
These two bundles behave completely differently depending on what your leg is doing.
Okay, let's break that down. Walk me through the tension.
Think about the anteromedial bundle first. This bundle is tight in flexion. When you bend your knee, like when you are sitting in a chair, that specific bundle engages and pulls taut.
Oh, got it.
Now take the other one, the posterolateral bundle. This one is tight in extension. When you stand up and lock your leg perfectly straight, the posterolateral bundle engages. And when the leg is straight, both of those bundles lie side by side, perfectly parallel to each other.
Okay, let me try to translate that into a working analogy. It's time to say it back.
Go for it.
Imagine you have a complex rigging system on a sailboat. You have two main ropes, the two bundles. They don't just pull at the same time. They trade off. When the sail is pulled one-way flexion, the anteromedial rope takes all the tension and goes taut, while the other rope gets some slack. When the sail swings the other way extension, the posterolateral rope snaps tight, and the first one relaxes a bit.
That is a much better way to look at it, because they are a dynamic team. They never fully disengage, but they trade the primary mechanical load back and forth as the knee bends and straightens.
Okay, that makes sense.
Now here's the clinical translation of that anatomy. If one of those ropes snaps, what specific function do you lose?
Well, if the anteromedial bundle is tight when the knee is bent, breaking it must mess up the knee's stability and flexion.
Exactly. Rupturing the anteromedial bundle causes massive anterior instability. In clinical terms, we call it a positive anterior drawer. It means if a doctor pulls your shin bone forward, it slides out of the joint too far because that specific bundle isn't there to check the forward translation.
Right.
But what happens if you rupture the posterolateral bundle?
That's the one tight in extension. So the leg becomes unstable when it's straight.
It does, but it introduces a totally new, highly destructive vector. Rupturing the posterolateral bundle gives you some anterior instability, but primarily it gives you rotational instability.
Rotational instability. So this is the bundle that stops the knee from twisting apart.
Yes. The posterolateral bundle is the rotation bundle. I want you to plant a massive flag right there. Remember our patient from the tennis court?
The cold open.
Yes.
Yep.
They could run straight, but the moment they pivoted, the knee gave way. That specific detail, that the posterolateral bundle controls rotation, is the key that will completely unlock that mystery later on.
I'm holding on to that. So we have our two bundles. They trade off tension, and they handle forward sliding and rotational twisting. But where exactly are they anchored?
Right, the anchors.
Because I'm looking at an anatomy chart, where does this thing actually originate? The medical texts in our sources say it arises from the, and I'm quoting here, posteromedial aspect of the medial surface of the lateral femoral condyle.
Yeah, that's a mouthful.
I need you to translate that into plain English because my brain just shut off halfway through that sentence. If I'm looking down at my own right knee right now, where is that?
Fair point. The anatomy textbooks do no favors there. This is our first trap, actually, the anatomy trap.
That's here.
Textbooks make you think in 2D words, but you have to build the 3D space. Look at your right knee. The bottom of your thigh bone, the femur, ends in two large rounded knobs. Those are the condyles. You have a medial one on the inside of your leg and a lateral one on the outside.
Okay, I can picture the two knobs.
Between those two knobs is a deep groove, a tunnel, called the intercondylar notch.
So a tunnel between the knobs.
Exactly. The ACL lives inside that tunnel. Specifically, it attaches to the inside wall of the outer knob. That is the medial surface of the lateral femoral condyle. It anchors deep in the back of that notch, and then it stretches forward and diagonally down to attach right in the center of the shin bone plateau.
So it's tucked away deep in the absolute center of the joint. It's not out on the surface at all.
No, completely internal.
That makes sense mechanically, I guess. It's at the core of the hinge. But let's talk about what happens when that core gets damaged. Picture an acute sports injury. A football player takes a nasty plant, the knee buckles inward, they go down clutching their leg. Usually within just an hour or two, that knee swells up incredibly fast.
Oh, massive swelling.
It gets tight, hot, and fills with fluid. Medically, that's called a hemarthrosis, a joint full of blood. This is our scar story. Why does a torn ligament bleed that aggressively?
Because the ACL is highly vascularized, and it bleeds heavily because of one very specific vessel. The entire joint is fed by a network of arteries, but the ACL relies almost exclusively on the middle genicular artery.
The middle geniculate?
Yes. The middle genicular artery branches off the main popliteal artery behind your knee. It pierces right through the back of the joint capsule.
Okay.
Inside the knee, the ACL isn't just sitting there naked in the joint fluid. It is wrapped in a synovial fold, a thin tissue sleeve. That sleeve is incredibly rich in blood vessels fed directly by that middle genicular artery.
So when the tremendous mechanical force snaps the ligament in half, it violently tears that highly vascular sleeve right along with it.
It shreds the sleeve, it severs those arterial branches, and the vessel just pumps whole blood directly into the enclosed capsule of the knee joint.
Wow.
That is why the swelling is so rapid and so incredibly painful. The joint capsule can only expand so much before the pressure becomes agonizing.
And this is where the medical literature sets a very specific trap for people trying to learn this. Because if you look at the vascular maps of the knee, there are a lot of arteries with very similar names. There's the superior medial geniculate, the superior lateral, the inferior lateral.
They all exist, yeah, and they all form a massive web of blood vessels around the outside of the knee. If we ever do a deep dive into the complications of total knee replacements or lateral release surgeries, we will absolutely talk about the superior lateral genicular artery.
But for the ACL?
For the core of the knee, the cruciates, the ACL and PCL, the supply is completely different.
It's essentially entirely soft tissue driven from that middle artery. There's no real blood supply coming up through the bone itself to feed it.
Exactly. The osseous or bony vascular contribution is totally insignificant. It is soft tissue dependent, middle geniculate, middle of the knee, middle of the notch.
Okay, so we've established the native architecture. We have a two-bundle ligament anchored deep in the central notch, heavily supplied by the middle geniculate artery, acting as a dynamic brake against forward sliding and rotational twisting.
Right.
That tells us how the machine works. But if a patient walks into a clinic with a swollen, painful knee, how does a doctor actually prove this specific internal structure is broken without cutting them open?
That brings us to decoding the damage. We have physical tests in the clinic, and we have diagnostic imaging. Let's start with the doctor's hands.
The physical exam.
When you lie on the exam table, the physician is going to try to manually pull your shin bone forward. This is anterior loading. If the ACL is torn, the bone will slide too far forward. But the angle of your leg during this test changes everything.
Right, because if you watch a sports medicine doctor work, they never test the knee straight, and they never test it bent at a perfect right angle. They always seem to unlock the knee and bend it just slightly. Why not pull on it when the leg is locked? Or when the foot is planted flat on the table at 90 degrees.
It all comes down to mechanical leverage and anatomical interference. The absolute gold standard physical exam for an ACL tear is the Lachman test.
The Lachman test.
And the Lachman test is performed at exactly 30 degrees of knee flexion.
30 degrees. Not 0, not 90. Why is 30 the magic number?
Let's break down the physics of it. If your leg is at 0 degrees, perfectly straight, the entire posterior capsule of your knee is pulled tight. Even if your ACL is completely obliterated, the tight capsule in the back of the knee will physically block the shin from sliding forward. You'll get a false negative.
Okay, so 0 degrees is out. What about 90 degrees? 90 degrees, that's the old anterior drawer test where the doctor sits on your foot and pulls.
Oh, this brings us to the hamstring trap. The anterior drawer at 90 degrees has massive flaws.
How so?
First, biomechanical studies show that anterior loading at 30 degrees produces vastly greater strain on the normal anteromedial bundle than at 90 degrees. 30 isolates the ligament better.
Got it.
Second, at 90 degrees, you introduce human interference. When a patient is in pain, their hamstrings instantly go into spasm to protect the joint. At 90 degrees, those spasming hamstrings act like a massive splint, physically pulling the tibia backward and preventing the doctor from sliding it forward.
So the patient's own defensive reflex ruins the test.
Exactly. And beyond muscle spasm, there is structural interference. At 90 degrees, the posterior horn of the medial meniscus can act like a physical wedge, doorstop, preventing the tibia from sliding.
Oh, wow.
By dropping the knee to 30 degrees for the Lachman test, you take the hamstrings out of their line of pull, you unlock the meniscal wedge, and you isolate the anteromedial bundle. It provides a clean, unmistakable endpoint.
You pull at 30 degrees. If you feel a firm, sudden stop, the ligament is intact. If you feel a soft, mushy, sliding sensation with no clear endpoint, the ligament is gone.
That mushy feeling is what every orthopedic surgeon is feeling for. Once they feel that positive Lachman, the next step is confirming it visually with an MRI. And on that MRI, there are distinct pathological clues we look for.
Let's talk about the visual clues, because an MRI isn't a photograph, it's a map of fluid and tissue density. One of the classic signs in the source material is the empty notch sign. What exactly are we looking at there?
Well, when you look at a healthy knee on a fluid-sensitive MRI sequence, you should see the dark, thick band of the ACL stretching across the intercondylar notch. The empty notch sign is exactly what it sounds like. You look at that central notch, and instead of a dark ligament, you just see bright white signal.
And on these specific MRI sequences, bright white means fluid.
Bright white is fluid, so seeing fluid right where the ligament should be anchoring to the femur is direct visual proof of an avulsion or a tear.
Makes sense.
And the clinical relevance of finding the empty notch sign is profound. We know the most common place for an ACL to tear is right in the middle, the midsubstance. It literally snaps in half like a frayed rope. But the second most common site of injury is right at that proximal femoral attachment.
It rips right off the bone.
It peels right off the anchor point. So if a radiologist scans the middle of the ligament and it looks intact, they cannot stop there. They must meticulously scrutinize that femoral attachment deep in the notch. If it's empty, the ligament has avulsed, and it's functionally useless even if the main body of it looks fine.
Now, fluid where the ligament should be makes intuitive sense. But let's talk about the bone bruise. This is a concept that genuinely confuses a lot of people.
Right.
If an ACL rupture is fundamentally a soft tissue injury, like a rope snapping, why are doctors intensely looking for bruises deep inside the bone marrow on an MRI?
Because the bruising tells the story of the violent physical collision that happened the millisecond after the ligament failed. This is pure, brutal mechanics. When the ACL snaps, the primary restraint holding the tibia in place is gone.
Right.
The tibia instantly translates anteriorly. It violently slides forward under the femur. And in almost all these injuries, there is an associated valgus force, meaning the knee joint buckles inward.
So the tibia slides forward, the knee collapses inward, the bones are no longer held in their natural alignment.
Exactly. And because they slide out of alignment under the massive weight of the athlete's body, they crash into each other. If the tibia shoots forward, the back half of the tibia forcefully collides with the front half of the femur.
It's a literal car crash inside the joint space.
It is a high-impact collision. Specifically, the posterolateral aspect of the tibia slams into the anterolateral aspect of the lateral femoral condyle. The impact is so severe that it causes microtrabecular fractures deep inside the bone, bleeding and edema within the bone marrow itself. That shows up as massive, bright white bone bruises on the MRI.
And this isn't just a rare quirk. The data shows this exact highly specific bruise pattern is present in roughly 80% of acute ACL injuries. 80%. If you see that specific bruise on the back of the tibia and the front of the femur, you almost don't even need to see the ligament to know what happened.
Time for the one-liner. The bruise is the fingerprint of the crime.
The bruise is the fingerprint of the crime. I love that.
And the anatomy of the femur actually dictates exactly where that bruise will occur. There's a normal, shallow groove on the lateral femoral condyle called the sulcus terminalis.
That's sulcus terminalis.
Yes. In a healthy knee, that shallow groove is simply the normal contact area where the anterior horn of the lateral meniscus rests when your leg is fully straight. But when the ACL snaps and the bones forcefully collide, they smash together right at that exact groove. The trauma can actually abnormally deepen the sulcus terminalis. Sometimes radiologists call it the lateral femoral notch sign.
So the normal architecture of the bone creates the perfect indentation for the collision to happen. We have the physical Lachman test, the fluid of the empty notch, the collision of the bone bruise.
Yeah.
Is there anything else? What if you don't have an MRI yet and you only have a basic old-school X-ray?
Even a standard radiograph can definitively diagnose an ACL tear if you know exactly what tiny detail to look for.
Okay.
You are scanning the X-ray, looking at the lateral side of the tibia, the outside edge of the shin bone plateau, and you see a tiny, almost microscopic fleck of bone that has been pulled away from the main bone. A small avulsion fracture.
That's the second fracture.
The second fracture. If you see that tiny chip of bone on an X-ray, it is essentially pathognomonic for an ACL tear. Meaning, if you have a second fracture, your ACL is ruptured until proven otherwise. You would absolutely expect to find a positive Lachman test the second you put your hands on that patient.
Right.
But the fascinating medical debate for decades was, what exactly pulls that chip of bone off?
Because bone doesn't just flake off on its own. A ligament or a tendon has to physically anchor to it, pull under immense tension, and rip the bone away rather than the tissue tearing. For a long time, the old textbook answer was just the lateral capsule. They thought the general tissue wrapping the joint just pulled too hard.
That was the accepted dogma, the lateral capsular avulsion. But anatomical science has advanced, and the current updated answer involves a highly specific structure, the anterolateral ligament, or the AL.
The AL. This is the structure that made headlines a few years ago when researchers claimed they discovered a new ligament in the human knee, right?
Yes, though French surgeons described it over a century ago, we finally formalized its biomechanical role recently. The anterolateral ligament runs from the outside of the femur down to the anterolateral tibia. and its job is crucial. It plays a massive role in rotational stability. It specifically controls internal tibial rotation.
There is rotation again. The posterolateral bundle controls rotation. Now this AL structure on the outside of the knee controls rotation.
And they are functionally linked. The valgus and twisting force that ruptures the ACL very frequently places massive tension on the AL as well. The AL holds on so tight that it literally rips a chunk of bone off the tibia before it fails. That is your second fracture.
Oh, wow.
And surgeons are now realizing that if a patient has persistent rotational instability after an ACL surgery, it might be because their AL was also destroyed in the initial injury and was never addressed.
Let's do a quick recap block. This paints such a chaotic picture of the injury. We know the anatomy, the two bundles. We know how to diagnose it at 30 degrees. But it's not just a clean snap of a single rubber band. It's a massive vascular rupture, filling the knee with blood. It's bones forcefully colliding into each other to cause marrow bruising, and it's rotational ligaments on the outside of the knee ripping chunks of bone off the tibia. It is a total ecosystem collapse.
Ecosystem collapse is the perfect phrasing, because the knee relies on a delicate balance of primary and secondary restraints. When the primary restraint, the ACL, goes offline, the other structures in that ecosystem are suddenly forced to take on mechanical loads they were never designed for.
Which brings us perfectly into the collateral damage, the meniscal timelines. When we talk about knee injuries, the two C-shaped cartilage shock absorbers sitting between the femur and the tibia are always heavily involved.
Always.
And there is a very famous classic medical trope here that we need to address. This is another trap, isn't it?
Yes, you are referring to the terrible triad trap.
Exactly, the O'Donoghue terrible triad. Every sports commentator talks about it. A player gets hit on the outside of the knee, and they supposedly tear their ACL, their MCL on the inside of the knee, and their medial meniscus all at exactly the same time. But diving into the modern data in our sources, that classic teaching seems to be wildly inaccurate as a standard rule.
It is a historical trap. The original terrible triad was described based on severe contact-heavy trauma. But in modern orthopedics, particularly with the non-contact pivoting injuries that make up the vast majority of ACL tears, the medial meniscus is actually not the most common collateral victim in the acute moment.
So if the ligament snaps right now, today, which meniscus is actually taking the damage?
In an acute, sudden ACL tear, the structure most likely to be injured alongside it is the lateral meniscus. Specifically, the posterior horn of the lateral meniscus. The data shows this happens in roughly 45% of acute tears.
45% of the time, the outside meniscus tears when the ACL pops.
Yeah.
Then why did the medial meniscus get all the fame in the terrible triad?
Because of timeline. The medial meniscus absolutely tears, but it usually tears later. It is a consequence of chronic ACL deficiency. If a patient ignores their torn ACL, doesn't get surgery, and tries to live their life for months or years with an unstable knee, the mechanical burden shifts. Without the ACL to stop the shin bone from sliding forward, the body desperately looks for a secondary restraint.
It needs a backup system.
And the medial meniscus becomes that backup system. Because of its wedge shape and how tightly it is anchored to the bone, the posterior horn of the medial meniscus acts like a physical chalk block, like putting a block of wood behind the tire of a truck on a hill.
Right.
Every time the patient steps and the tibia tries to slide forward, the medial meniscus physically blocks it.
But cartilage isn't designed to be a primary structural brake for humans' entire body weight. It's a shock absorber. It handles compression, not constant forward shear force.
Exactly. It handles vertical load beautifully, but it cannot survive constant anterior shear force. Over time, that repetitive grinding stress physically degrades the cartilage. Eventually, the peripheral posterior horn of the medial meniscus just burns out and fails. It tears, and this chronic pattern is staggeringly common.
Let's put the numbers to it, because they are jarring.
In chronic ACL-deficient knees, medial meniscal tears are present in approximately 70% of patients.
70%. So almost 3/4 of people who try to live without an ACL will eventually grind their medial meniscus to pieces. That feels like an incredibly strong argument for early surgical intervention.
It is.
If you rebuild the primary restraint quickly, you save the backup generator from exploding.
It is the primary biological argument for early reconstruction. You want to preserve the meniscal cartilage to prevent early-onset osteoarthritis. But, and this is a critical nuanced caveat in the literature, you have to understand how that backup system functions after you do the surgery.
Okay, lay the caveat on me.
If you look at long-term studies evaluating anteroposterior laxity, how loose the knee is back to front years after an ACL reconstruction, several things heavily influence that stability. The exact placement of the surgical tunnels influences it. The type of graft tissue selected influences it. The timing of the surgery influences it. But one thing does not significantly influence the long-term surgical laxity: the integrity of the medial meniscus.
Wait, that sounds completely contradictory. We just spent the last 5 minutes explaining that the medial meniscus acts as the critical secondary restraint to stop the knee from sliding. Why wouldn't a torn medial meniscus make the surgically repaired knee looser?
Because it is only a functional restraint in the deficient knee. When the ACL is gone, the meniscus steps up. But once a surgeon successfully rebuilds the ACL and puts a strong tension graft in its place, the new primary restraint takes over the load entirely.
I see.
The secondary restraint is essentially relieved of its braking duties. Therefore, whether the medial meniscus is perfectly intact or partially torn doesn't actually alter the long-term stability of the newly reconstructed joint.
So if the primary structural pillar is solid, it doesn't matter if the scaffolding is a little damaged.
Exactly. What matters is the engineering of that new primary pillar, which brings us out of the diagnosis phase and directly into the operating room, the geometry of surgery. And this is where we finally circle back to the medical mystery of our tennis player from the cold open.
Right. We had a patient with a perfectly continuous, healthy-looking graft on their MRI, but a knee that physically buckles when they pivot. How does a structurally sound graft fail functionally?
It fails because of architectural error. The most critical step in an ACL reconstruction is where the surgeon drills the bone tunnels to anchor the new graft. A millimeter of deviation changes the biomechanics of the entire leg. Let's look at the most common technical errors, starting with the anteroposterior plane front to back.
What is the most common mistake a surgeon can make with the drill?
The most common error is placing the tunnels too far anteriorly, too far forward. This can happen on the femur, the tibia, or both. And each mistake produces a specific, agonizing result for the patient. Let's start with the femoral tunnel, the anchor in the thigh bone. If a surgeon drills that hole just a few millimeters too far forward, what happens dynamically as the patient tries to move?
Well, if the anchor point is moved forward, the arc of the ligament changes.
It changes drastically. An anterior femoral tunnel creates a graft that is extremely tight in flexion and completely lacks in extension.
Tight when bent, loose when straight.
Yes. And because it is excessively tight in flexion when the patient attempts to straighten their leg, the biomechanics are fundamentally mismatched. The graft physically impinges against the intercondylar notch. It rubs forcefully against the bone.
And the human body hates friction.
The body responds to friction with inflammation and scar tissue. Because that graft is constantly rubbing and impinging, the body builds a massive, dense nodule of fibrous scar tissue sitting right at the front of the graft.
A Cyclops lesion.
The Cyclops lesion. It's named because on an arthroscopic camera, it looks like a distinct, solitary eye staring back at you. That dense lump of scar tissue acts like a physical pebble trapped in the hinge of a door. It physically blocks the knee from reaching full extension.
So the patient will literally be unable to straighten their leg, all because the femoral anchor was a millimeter too far forward.
Exactly. Anterior femoral tunnel leads to tension mismatch, leads to impingement, leads to a Cyclops lesion, leads to a devastating loss of extension. Now, what if the surgeon gets the femur right, but drills the tibial tunnel, the lower anchor, too far forward?
Does it cause the same problem?
It causes the same clinical loss of extension, but through a different mechanical collision. If the tibial tunnel is too anterior, the graft is positioned too far forward in the joint space. As the patient tries to straighten their leg, the graft physically hits the top of the intercondylar notch, the roof of the femur.
A bony collision.
Yes, we call it roof impingement. The graft smashes into the bone before the leg can fully straighten. So whether the error is on the femur or the tibia, an excessively anterior tunnel costs the patient their ability to extend their knee.
Anterior cost extension. That is a brutal mechanical reality, but neither of those explain our patient. Our patient could straighten their leg just fine. They had full range of motion. Their problem was instability when turning.
Which brings us to the final geometric error and the solution to our cold open. If a patient has a continuous graft on MRI, a perfectly normal Lachman test, where the knee doesn't slide forward but they have severe rotational instability, there is only one anatomical explanation. The surgeon drilled a vertically inclined femoral tunnel.
Okay, say it back time. A vertical tunnel. Explain the geometry of that. Why does straight up and down equal failure?
Look at a native natural ACL. We established earlier that it anchors deep on the side wall of the notch and comes diagonally down to the tibia. It runs obliquely across the joint space. It has a vertical component, yes, but it has a massive horizontal component. That diagonal horizontal obliquity is exactly what acts as a seatbelt against rotational twisting forces.
But if a surgeon drills the tunnel straight up and down,
If they drill it straight up into the roof of the notch, which used to be a very common technique, often referred to as the 12 o'clock position on a clock face, the new graft runs almost purely vertically.
right, and a purely vertical rope can't stop a horizontal twist.
Exactly. It resists anterior translation beautifully. When the doctor pulls the shin forward in the clinic during the Lachman test, the vertical graft holds it perfectly tight. The test feels incredibly solid. The MRI shows a thick, intact graft.
But
Time for a second one-liner. A vertical structure has an effective lever arm of 0 against a twisting tibia.
a vertical structure has an effective lever arm of 0. Wow. So the surgeon rebuilt the anteromedial bundle's function, stopping the forward slide, but they completely failed to recreate the posterolateral bundle's function, stopping the rotation.
You nailed it. The physical graft material is intact, but the direction of the vector is entirely wrong. The patient's knee is stable in the linear plane the doctor tests on the exam table, but entirely unstable in the multidirectional rotational plane the patient actually lives and plays sports in.
That is mind-blowing. A perfectly healed ligament that is entirely useless because of the angle. So how do they fix it?
The only way to fix a vertical tunnel is a complete revision surgery. You have to go back in, drill a new, properly oblique tunnel at roughly the 10 o'clock or 2 o'clock position to restore that horizontal geometry and put a new graft in.
Which transitions us perfectly to the actual materials used in these surgeries. If the geometry is dialed in, you need to decide what physical tissue is going into those tunnels. You generally have two choices: an autograft, taking tissue from the patient's own body, like their hamstring or patellar tendon, or an allograft, using donor tissue from a cadaver.
Let's focus on the allografts, because using donor tissue introduces a massive biological variable: sterilization.
Right.
If you take tissue from a deceased donor, you must ensure it is entirely free of bacteria, viruses, and pathogens before you implant it into a healthy athlete. But how you sterilize it dictates whether the surgery will succeed or fail.
This is the sterilization trap. The source material is very clear that there are wrong ways to do this. Gamma irradiation is one of them. It sounds incredibly high-tech and sterile, but what does blasting a tendon with gamma rays actually do to the tissue?
Gamma radiation is essentially firing high-energy photons at the tissue to destroy pathogen DNA. It works wonderfully for sterilization, but it is violently destructive to the physical material.
How so?
Tendons and ligaments get their immense tensile strength from a complex network of collagen fibers bound together by chemical crosslinks. Gamma radiation actively breaks those covalent bonds.
It fundamentally alters the collagen morphology.
Yeah, it physically weakens the structural and mechanical properties of the graft. You've killed the bacteria, but you've turned a steel cable into a frayed, brittle rope. Studies show a significant dose-dependent decrease in the tensile properties of irradiated allografts. They stretch and tear far easier than native tissue.
So radiation physically destroys the strength, and then chemicals poison the joint environment, because ethylene oxide is another method mentioned.
Ethylene oxide is a toxic gas often used to sterilize plastics and medical equipment, but using it on porous biological tissue is a disaster. The gas permeates the tissue and toxic residues remain trapped within the collagen matrix. When you implant that chemically treated graft into a living human knee, the patient's immune system detects the residue.
And the body attacks it.
The body mounts a massive inflammatory response. It stimulates a severe, angry, intra-articular reaction, widespread synovitis. The joint swells, becomes incredibly painful, and the inflammatory enzymes can actually degrade the graft tissue from the inside out.
Let's hit our second recap block. So radiation physically destroys the strength, chemicals poison the joint environment, an anterior tunnel ruins your extension, a vertical tunnel ruins your rotation, and your medial meniscus only acts as a brake when everything else is broken. What is the actual gold standard here? How do you use a cadaver graft safely?
The universally accepted method is sterile harvesting combined with deep freezing. You treat the organ donation just like a live surgery. You harvest the tissue in a completely sterile operating environment to prevent contamination from the start, and then you deeply freeze it. Freezing preserves the structural integrity of the collagen matrix without introducing reactive chemicals or destructive photons.
If it's this complicated to process, why use donor tissue at all? Why not just use the patient's own hamstring every time?
Because harvesting an autograft has a cost. Using donor allograft completely avoids donor site morbidity. You aren't cutting out a piece of the patient's patellar tendon and creating a second painful wound site. It diminishes postoperative pain, and it shaves significant time off the surgery.
But there has to be a biological trade-off.
There is. An allograft is dead tissue.
Yeah.
When you implant it, the patient's body has to slowly undergo creeping substitution macrophages, clean out the dead donor cells, and the patient's own fibroblasts lay down new living collagen along the scaffold.
Oh, wow.
That biological incorporation is significantly slower than using an autograft. It can take months longer for the graft to become biologically strong.
So you buy a faster, less painful early recovery, but you pay for it with a slower biological healing timeline deep inside the bone. That makes the rehabilitation phase incredibly precarious.
And rehabilitation is where we see the final tragic failures.
Yeah.
Let's move into the nuance in practice. Surgery isn't just raw mechanics. It happens inside a living, changing patient.
Let's do this as a lightning round. We've got 4 rapid-fire topics: the pediatric dilemma, environmental risks, the brace illusion, and the gym trap. Let's start with kids. Operating on growing children. Kids are tearing their ACLs at staggering rates now with year-round competitive sports. But their bones aren't finished growing.
That is the terror of pediatric orthopedics. Long bones grow from the ends at the physial plates, the growth plates. If a 15-year-old tears their ACL, the surgeon has to decide whether to drill massive tunnels straight through those active growth centers.
What happens mechanically if you put a highly tensioned soft tissue graft right across an open lateral femoral physis?
Let's visualize the geometry again. The femoral tunnel is drilled on the lateral side of the femur, the outside. If you run a tight, strong ligament through that tunnel and anchor it, you essentially staple the outer edge of the growth plate shut. You mechanically tether the lateral aspect of the distal femur.
So the outside of the bone physically cannot grow anymore because it's held tightly together.
Exactly. But the medial side, the inside of the knee, is untethered. It's completely free. So as the child ages, the inside of the femur continues to grow longer while the outside is stuck. The bone physically curves, the leg angles outward, away from the midline.
You induce a valgus deformity. The kid ends up intensely knock-kneed.
You cause severe femoral valgus, and the critical factor is the tension. It is the highly tensioned nature of the graft that causes the mechanical tethering.
But knowing that terrifying risk, surgeons still perform this operation on kids whose growth plates are wide open. Why take the risk?
Because the alternative is often worse. Imagine a 15-year-old volleyball player. She tears her ACL right off the femoral attachment. She goes through 6 weeks of intense, conservative physical therapy to strengthen her muscles, but every time she steps back onto the court and tries to pivot, the knee violently gives out.
Functional instability in a pivoting sport.
Precisely. Failed conservative rehabilitation combined with functional instability in a high-demand cutting sport completely overrides the argument for waiting. If you tell that child to just wait 3 years for her bones to finish growing, those recurrent giving way episodes will completely obliterate her menisci and her articular cartilage.
Yeah, that makes sense.
She will have bone-on-bone arthritis by the time she's 20. You have to reconstruct the ACL utilizing specific pediatric techniques that try to minimize physical damage to save the joint.
Next in the lightning round, environmental risks. We spend so much time debating anatomical risk factors, whether women are more at risk because of wider pelvises, or whether the exact millimeter width of a patient's intercondylar notch dictates their destiny.
The medical literature is full of debates about anatomical destiny, but when you look at the hard, definitive evidence regarding non-contact ACL injuries, the most heavily supported factor isn't something you are born with, it's something you wear.
It's the shoe surface interface.
The only definitively evidence-based risk factor with robust consensus is a high coefficient of friction at the shoe surface interface.
So we were talking about cleats on artificial turf.
Yes. When an athlete plants their foot to change direction, the shoe is supposed to have a slight amount of slip to dissipate the rotational force. If the cleat grips the artificial turf too perfectly, the foot is locked in cement. All of that rotational torque travels instantly up the shin bone and directly into the knee joint. The ACL absorbs the entire load and it snaps.
Wow.
You are statistically far more likely to tear your ACL because of the intense grip of your shoes than because of the inherent shape of your femoral notch.
That is fascinating. The most dangerous factor is the one we synthetically created for better traction. Okay, lightning round topic 3, the post-operative environment. The patient survives the surgery, the tunnels are perfect, the graft is sterile. They wake up, and the surgeon immediately straps a massive, expensive, hinged functional knee brace onto their leg.
The functional brace. It is practically a status symbol of knee surgery. But what does the clinical data actually say it accomplishes?
Intuitively, you assume it protects the graft from tearing again. You assume it stabilizes the joint while it heals.
That is the intuition, but it is a clinical illusion. If you look at randomized controlled trials comparing patients who wear a functional brace after surgery to those who just use a simple neoprene sleeve or nothing at all, the results at the 2-year mark are unequivocal. There is absolutely no difference in joint stability, range of motion, overall function, or pain levels at 2 years, 2 years.
So the brace physically changes nothing about the final healed knee at 2 years, 2 years.
Nothing, but it does have one measurable negative effect early on. The braced group actually demonstrates significantly more quadriceps muscle atrophy at the 3-month mark.
At 3 months? 3 months, because the brace is doing the work the muscle should be doing.
Exactly. The brace acts as a psychological crutch. It makes the patient feel confident, which has some value early on, but it physically offloads the quadriceps. The muscle wastes away faster. By 2 years, the brace makes zero difference to the joint, but it actively delays your muscular recovery in the first critical months.
Which brings us to the final lightning round topic, and perhaps our most tragic trap, the gym trap. Rebuilding the quadriceps is the holy grail of ACL rehab. A patient is 6 weeks out, they are feeling great, they want to rebuild that atrophied quad muscle, so they go to the gym. They sit down on the seated leg extension machine, the one where you hook your ankles under the padded bar and straighten your legs out against the weight stack.
And in doing so, they initiate a catastrophic mechanical failure.
Explain the physics of why that specific machine is so dangerous.
It comes down to open chain versus closed chain kinematics. The seated leg extension is an open chain exercise. Your foot is freely moving in the air. When you push against that padded bar, particularly as your knee goes from 90 degrees up to about 0 to 30 degrees, 0 to 30 degrees of extension, the machine places a massive, unopposed anterior shear force directly on the tibia.
It is physically grabbing your shin and pulling it forward.
Yes. And what is the primary structure inside the knee designed to stop the shin from sliding forward?
A new, delicate, healing ACL graft.
Exactly. There is no co-contraction protecting it. If you do a closed chain exercise, like a squat or a leg press where your foot is firmly planted against a solid surface, your hamstring muscles engage simultaneously with your quads.
Right.
The hamstrings pull the tibia backward, completely neutralizing the forward shear force. The joint is compressed and protected, but on the seated extension machine, the hamstrings are asleep. The machine pushes the tibia forward, and immense strain goes straight into the biological graft.
And the tragic part is, the graft doesn't usually snap violently. It's not a sudden, dramatic injury.
It is insidious. The patient does their 3 sets of 10, 3 days a week, and slowly, continuously, they stretch the biological tissue. The collagen fibers elongate. It's like pulling on a cheap rubber band until it loses its elasticity. A month later, they come back to the clinic complaining that the knee feels loose again. The surgeon performs a Lachman test, and the firm endpoint is gone. It's soft and mushy.
The graft is technically intact on an MRI, but it has been stretched permanently.
And you cannot unstretch a graft. Once the tension is gone, the ligament is functionally useless. The patient ruined a perfect surgery simply by picking the wrong machine at the gym. Rehabilitation must rely entirely on closed-chain kinematics in the early phases.
We have mapped this entire journey. Let's synthesize exactly what we've uncovered. We started with the native blueprint, the anteromedial bundle holding the line and flexion, the posterolateral bundle controlling the vital rotation and extension. We watched how the middle geniculate artery causes the knee to balloon with blood.
We decoded the diagnostic clues. Why the Lachman test at 30 degrees isolates the bundle while avoiding the hamstring and meniscal traps of the 90-degree drawer. We saw the empty notch sign, the violent bone bruising from the subluxation, and the Segond fracture warning us of associated rotational damage.
We explored the collateral timeline, how the lateral meniscus often tears acutely, but the medial meniscus slowly grinds itself to death, acting as a backup brake and a chronic deficient knee.
We detailed the maddening geometry of the surgical tunnels, how an anterior tunnel causes a Cyclops lesion and a permanent loss of extension, while a vertical tunnel creates a perfectly normal-looking graft that fundamentally fails to control rotation.
We analyze the destructive nature of gamma irradiation on collagen, the biological tethering of the pediatric growth plate, the environmental danger of shoe surface friction, the muscular atrophy caused by functional bracing, and the slow, tragic stretching of a perfect graft on an open-chain leg extension machine.
We have outlined exactly how to understand, diagnose, and perfectly reconstruct an anterior cruciate ligament.
But we can't end a deep dive without pushing the boundaries one step further.
We have to leave you with a provocative thought to mull over. We just spent this entire time obsessing over the perfection of the ACL reconstruction, the 30-degree tests, the oblique tunnel geometries. But the reality of modern sports medicine is incredibly humbling, because large-scale studies are showing that one of the most common causes of a failed ACL reconstruction isn't a misplaced tunnel, and it isn't a stretched graft from a gym error.
Meaning all this surgical and geometric perfection we just discussed can be completely undone by something else entirely.
Yes, it can be entirely undone by an unrecognized injury to a completely different secondary structure sitting quietly in the back corner of the knee, the posterolateral corner, or the PLC.
The posterolateral corner?
The PLC is a complex web of ligaments and tendons that acts as the ultimate backup system for rotational and varus stability. And it is widely considered the single most underdiagnosed structure in the entire joint. Because it sits so deep and its physical exam tests are so incredibly subtle and complex, many surgeons simply miss it in the acute trauma bay.
So the surgeon perfectly rebuilds the central pillar, the ACL, but they completely fail to realize the foundation behind it is shattered.
Exactly. And because the PLC is shattered, the new ACL is forced to endure massive, abnormal rotational forces it was never designed to handle alone. Over the course of a year, those unchecked forces simply rip the perfect new ACL graft right out of the bone tunnels. Everything we just spent this time detailing fails completely because of a backup structure the doctor forgot to physically examine.
A perfect surgery ruined by the blind spot. Thank you for joining us on this deep dive into the hidden architecture of the knee. The next time you pivot or watch an athlete buckle on the turf, you'll look at the silent mechanics and the maddening geometry of that joint completely differently.